I heard some noise, so I guess somebody's logging in. Okay. Hello and welcome to the latest presentation in the National Telehealth Resource Center's webinar series. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. They are usually the third Thursday of each month. Located throughout the country, just a second. Located throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each serves as a focal point for advancing the effective use of telehealth and supporting access to telehealth services, primarily in rural and underserved communities. Just a few tips before we get started. Your phone and/or computer microphone has been muted. Time is reserved at the end for question and answer, and we'd be glad to take your questions. Please fill out the post-webinar survey. This webinar is being recorded and will be available to you on our YouTube channel that is also available on the National TRC website. Today's webinar is being presented by the TexLa Telehealth Resource Center that serves Texas and Louisiana. It is my pleasure to introduce our speaker for today. Jennifer Humbert is the Solutions Development Manager for Ochsner Health System's CareConnect 360. The Ochsner CareConnect 360 program utilizes telehealth to complement and enhance the patient care provided by on-site physicians to expand the depth of patient management options beyond a purely physician coverage model. Please welcome Ms. Humbert.
Thanks, Becky. So I'm going to go jump right in and go ahead and get started. I'm just kind of going to go through our objectives first. And as I'm going through the objectives today, I'm going to give you some key words and triggers to think about as we're going through the talk today. So we want to identify the link between the triple aim and remote patient monitoring and how we can improve patient care. And when we're talking through that, I'm really going to emphasize the patient experience and how the patient experience and satisfaction can really impact our quality outcomes, move the marker on quality outcomes in population health. We're also going to talk about remote patient monitoring in the home, and I think that that's a topic that is very high on everyone's list. It has a lot of hype right now, so I'm going to share with you some of the programs that we do from a remote patient monitoring standpoint in the home. And then I'm also going to talk about acute care remote patient monitoring, and that was really our first phase of remote patient monitoring, and that's remote monitoring in the ICU settings, the acute care settings, and I think sometimes we forget about remote patient monitoring still being EICU. And then identifying milestones on how you leverage technology within your organization. We came through a lot of decision points whether to buy it or build it, and I'm going to talk a little bit about how we build it. So there's a lot of forces that support telemedicine in our environment today. So the aging population. So our population continues to age, which means that the incidence of chronic disease is continuing to rise. cost containment expectations. Everyone that I talk to anymore from any hospital system across the country, most of the time when we're talking in some way, shape, or form, the concept of lean programs come up in hospitals. And anytime anybody has a lean program, they always seek to, well, wonder if telemedicine can help us. Higher acuity patients. We're discharging patients earlier. We're discharging them home with higher acuity. We're discharging them to nursing homes and long-term acute care facilities with higher acuity. And so then there's always questions going, how can telemedicine help support these patients in these areas with higher acuity? Changing regulations. Our regulations are always changing, and they're actually changing for the better when it comes to telemedicine and reimbursement. Pay for performance. We've been talking about pay for performance for many years. I finished my master's in healthcare administration a few years ago, and it seemed like almost every paper I did had some sort of buzzwords in there about pay for performance, and I think that we're finally really starting to truly feel those effects. And consumer adoption. Our patients want this. As the manager in development in the telemedicine program here at Ochsner, I get the privilege of working with all of our physicians and all of our service lines on developing new telemedicine programs. I was at a physician retreat about 6 months ago, and one of our physicians came up to me and he said, you know, I wasn't on board with this whole telemedicine thing, but I had a patient in the office the other day tell me I needed to be doing this for her. So our consumers are wanting this, and they really want it. And it's more that they don't just want this, they want a good experience when they have a telemedicine program. We have the technology out there that enables our telemedicine and remote patient monitoring programs. You know, our patients want it, they've told us that they wanted it, and I just gave you the example of a physician coming to me and, you know, his patients are asking for it, and we need it. We need it to be able to serve the populations that are in need. But what really makes this important is the patient experience and how the patient experiences the interactions with the provider. When we're developing our programs, we always want to keep our patients in the center, and we always know that when we're working with our physicians and in our service lines, that if we're doing that, then we're going to put out a good program. And why do I keep dragging on about the patient experience? Because we know that when the patients have good experiences and they have high customer satisfaction, we see improvements in medication adherence. We have increased patient compliance, decreased admissions, readmissions, this holistic approach to care, and we see better quality outcomes. So telemedicine and remote patient monitoring, and some of the other biggest benefits to this is cost avoidance. So when our patients are happy, they're following their care plans a little bit better. And we have the opportunity in telemedicine and remote patient monitoring to help us avoid cost and care. It creates operational efficiencies from a physician staffing standpoint, that they can actually see and treat more patients, improves quality, and reduces unnecessary utilization. And that can directly be related to reducing those unnecessary readmissions if we're able to catch things early in our chronic disease management programs and in some of our remote patient monitoring. So I just talked about patient experience, population health, and cost. And the Institutes for Healthcare Improvement has challenged us to really think about those three things in a critical way and how we can improve the quality of care that we're giving while reducing costs. And when we're talking about telemedicine and our remote patient monitoring programs, we can really tie things directly back to the major pinpoints of what the Triple Aim is asking us to do. Some more things that are pushing telemedicine and remote patient monitoring are the industry trends. So when I started telemedicine and I gave my very first talk about telemedicine, I referenced some of the old studies with pre-hospital care and how we were trying to give pre-hospital stroke care in the back of an ambulance, and this was being done in the 90s, and it was an epic fail because of the wireless connectivity and the way that we could connect wirelessly to the back of an ambulance. And I remember myself giving the reference of, do you remember dial-up internet when, you know, you heard the pa-ching, pa-ching, poosh, and it took you 10 minutes to get connected. Well, you know, we really don't live in that day and age anymore, and our wireless coverage continues to get better and better. And I'm not saying that our broadband access is great everywhere, but one thing that we have noticed in Louisiana is that we have 100% broadband coverage now in Louisiana. So that's really driving our forces to adopt this remote patient monitoring and telemedicine theory a little bit more. Smartphone ownership. So recently, within the last year, my grandmother got her first iPad, and I can no longer keep her off of Facebook now. So more and more people own smartphones, more and more people, you know, whether it's the younger generation or an older generation, our smartphone and tablet devices are easy to use, and a lot more people have them now. Our regulations continue to change. We keep, more and more states now have telemedicine parity laws. We have increase in reimbursement, and we have changes in lobbying for legislation going on continuously. And things aren't at its optimal state, but it continues to get better. And adoption, you know, wearable adoption, now we're seeing more and more people with Fitbits. There's Android devices, there are Apple devices out there. Just about every operating system that you can think of, there's some type of a wearable device or some type of watch that somebody wants to wear. And not saying that that the wearable devices are magic within themselves, but I think I think back to last Christmas and the trends for everybody to get an Apple Watch, and I can remember talking to groups of people in many different places, and they're wanting their Apple Watches or their Fitbits, or Garmin has something out now, and there's many different places that have these things out, and it's the moment that I put it on, I'm going to get this fitness app, and I'm going to be skinny, and my blood pressure is going to be under control, and it's going to work like magic. It doesn't quite work like that, but it does give us that little bit of motivation and self-control in wanting these wearable devices, and then how these wearable devices can help us. So in thinking about that, I'm going to go into some of the things that we did in chronic care with remote patient monitoring, specifically now bridging to some of these wearable devices. So chronic disease. Something that we're all entirely too familiar with. 75% of the U.S. healthcare dollars goes to the treatment of chronic disease, nation's leading cause of death and disability, causing 70% of all deaths. And I think that we, you know, like I said, we can all relate to someone who has chronic disease, or it's a part of someone that we know. It is a part of their life. So we developed a hypertension digital medicine program, and this is where we really focused in on blood pressure control. And me being a nurse by background, when I think of blood pressure control, you know, we're really trying to reduce heart attack and stroke. And some of the, you know, in the literature in the population, stroke used to be the 3rd leading cause of death, and then it went down to the 4th leading cause of death, and down to the 5th leading cause of death. And that continues to support this. We have an aging population, we're having higher acuity patients, and so we're keeping patients alive longer with stroke, but it's still the leading cause of long-term disability in the country. So if we can even take a couple steps further back and kind of look at that proactive approach in controlling blood pressure before a heart attack or stroke happens. So in this study, you can see we used apps and blood pressure cuffs, and this was more of an app-based protocol for us. The patient, you can see our patients typically got over 250 blood pressure readings versus the 3 clinic visits that they would get a year. So, you know, typically patients with hypertension, they come into if we can get them into the clinic 3 times a year, that's great. Sometimes we don't even get that. So we get very little blood pressure readings from that clinician standpoint. With this program, it showed that they got a tremendous amount more of blood pressure readings, and that we were actually able to see great outcomes with that. Our patients that received usual care, about 31% of them were achieving blood pressure control within 90 days. And the patients who were in the digital hypertension medicine program, there was 71% of those patients that received hypertension control within 90 days. And that was just amazing. And this was really using app-based telemedicine and emails and text messages between providers and patients. And you can kind of see at the bottom left-hand side of the screen, our patient enrollment is growing rapidly. In 2016, in Q2, we had 488 patients enroll. And that's just, and that's kind of telling us once we get the word out there and people are seeing this, our patients do want it, they do want to enroll, and we are seeing good compliance rates with this. So that also led us to the fact that patients do like apps, and they do prefer apps. And so out of 2,000 patients with chronic disease and a smartphone, 66% of them were willing to fill a medication that was prescribed by a doctor, but 90% of them were willing to use an app prescribed by a doctor. So one of the things that we did within our system for that is then we started recommending specific apps. Out there for the general public, it can be very difficult for people to really choose a good app. Most people choose an app by the number of stars next to the little application, and if it has 4 stars, then it must be a good app, right? And that's not necessarily the case, and that's not necessarily what's best practice or supported by our physicians. So we actually developed a program where our physicians can prescribe an app, and then a place for our patients to go that they can get technical support to be able to download that app, and then be able to purchase the blood pressure cuffs and different equipment that are compatible with the application that their provider recommended. So congestive heart failure. So we're talking about hypertension and congestive heart failure. Why is congestive heart failure so important for us in remote patient monitoring? Well, if you didn't know, it is the #1 reason for readmissions to the hospital. So as we're thinking about trying to control population and reduce cost and have good patient experiences, we felt that this was a pretty good place to start. So we do have a congestive heart failure home program where patients that meet criteria get discharged from the hospital with a digital scale and some technology and a tablet. And they do home monitoring. They do home monitoring daily weights and some other aspects of their health care. One of the most important pieces to this program, though, is the people that are involved. So we have dedicated heart failure nurses and pharmacists that actually run this program. They're able to look at what the patient's daily weights are and kind of what they're doing on a daily basis. And if they see something that's out of the ordinary or triggers them to make a phone call to the patient, they will. And they'll go ahead and they'll make a phone call to that patient, or they'll send them an email, or they'll send them a text message. And some of that comes back to that patient experience where what does the patient want and what's going to help them be most compliant. With this, we've actually found some great results early on. 30-day readmission rates for patients in this program decreased by 40%, and our 30-day mortality rate decreased by 90%. So we're seeing great results in these programs early on from a remote patient monitoring perspective. And for this program specifically, how we did this with the pharmacists and the heart failure nurses, we're going to expand those services to our hypertension patients that were just receiving some digital medicine previously in the first study that I talked about. So one of the things that we've done at Ochsner and that some of you may have heard of is that we did partner with Apple to integrate into our EMR. So we were the first in the world to integrate the Apple Health Kit into our Epic EMR. One of the things that I strongly suggest, and no matter how you're using your remote patient monitoring programs or whatever applications or apps or whoever you're partnering with, is to let your EMR work for you. Work with your Epic teams, your Cerner teams, whoever you have, and work to make your system smart for you. And what that really allows in the remote patient monitoring at home and remote patient monitoring in the acute care setting, when we have have smart systems and we have triggers and alerts and electronic systems that draw our eyes to certain patients, one, it allows us to more effectively take care of those patients and keeps us compliant in those best practice standards. And then it also allows your team of people to be able to care for more patients effectively. And in this world of wanting to be lean and do the responsible thing and be good stewards of healthcare dollars, that's really important to be able to safely maximize our patient loads. And we found that really partnering very heavily with our EMR and our electronic systems has helped us gain a lot of success. In chronic disease, you know, I talked a lot about hypertension and heart failure, those cardiac diseases, but in chronic disease, you know, we're going to see more and more with programs on smoking cessation, weight loss, behavioral health, and more innovative remote patient monitoring programs coming forth. I just spoke with a group and that we're going to be developing, and this is one thing that I did not even have on my radar, but I had the group of physical therapists come to me and they want to talk about remote monitoring for therapy services in the home. And there's actually technology out there that works like an Xbox Connect or works just like your Wii Fit at home. Patients can do their therapy exercises at home. The technology can monitor how they're doing, if they're doing their exercises correctly and at the rate and amount of times per week that the therapist wants them to do it. And then the therapist can come back, evaluate, check in with the patients, and they may see, hey, you're really not doing this exercise correctly. Why don't we have you come back in for one therapy session to make sure you're getting what you need, or you're doing great, wonderful, it's time to discharge you from therapy. That creates a good patient experience many times from our patients in therapy services. We hear that it's hard for them to get to therapy 3 or 4 times a week. This allows them to get that in their home safely and knowing that they're doing their exercises appropriately. So lots more to come with remote patient monitoring. I'm going to shift gears and talk a little bit about our acute care remote patient monitoring programs. One of them being our EICU. EICU is that remote patient monitoring of the acute care patients in the ICU, and they're really doing proactive and reactive monitoring here. We do at Ochsner use Philips for our EICU software, and it allows it allows for that extra set of eyes and that extra set of quality to be given to the patients in the ICUs in our community hospitals. One of the most important things in the EICU programs is that we don't take this extra set of eyes for granted, in the sense that this is not a way to reduce staffing at the bedside, or is not a replacement for staffing at the bedside. It truly is an extra layer of quality and help. So they can proactively look at labs and vital signs and see trends. They can look at those trends at a higher level. Sometimes when you're at the patient bedside, you're just seeing what those vitals were for the last couple hours within your shift. But what the nurses in the EICU can do is they can trend what that has been over the last 24 to 48 hours to really see early changes, whether patients are improving or not improving. EICU programs have been proven to reduce length of stay, reduce mortality, reduce ICU length of stay, and reduce hospital services and costs. And a lot of times when we can be proactive and use best practices, our patients need less resources from the hospital, and that's how we really decrease the cost. What we've also found is that our patients really like it. Our patients and our families truly like the EICU program. One of the things that we have in our model of care, and it's actually at the bottom of this slide, is nurse mentoring. So if you know anything about nursing, new nurses always get stuck on night shift. So So I know that's typically when with my family members in the hospital, that's typically when I get nervous. Those nurses that are on night shift are usually all of the new nurses. And so what we can do for them is be that extra set of eyes in the background for them and provide mentoring if they need it. So if that nurse on night shift has a question, they can actually call the EICU and say, hey, let's look at this patient together. Or, you know, I really don't know if I want to call my attending or not yet. And they just need that backup from that seasoned ICU nurse to say, yes, you absolutely should be calling that attending. And if you want me to call them for you, I will. So it really does provide that nurse mentoring and allows patients' family members to go home in the evening and have a good sense that their loved one is going to be taken care of. We also help in disease management. Specifically, I'm going to just point out a couple of these: medication titration and medication drip checks. Many times we proactively round on all of our ICU patients, and we do drip checks on all of the patients to make sure they're on the right medication and the drugs are infusing at the right rate. It's amazing how many times we actually do find medication errors, and it's really scary to think that that goes on across our system, but it is true, and we're all human, and we have found drips running at the wrong rates or the wrong medications in, and not because of anybody being malicious, but it is just a mistake that can be made. Managing best practices. One thing that we do in our EICU is we participate in all cardiac arrests and all codes. We are able to be that set of eyes that is looking at that higher level, not in the chaos of the room, and we can help them follow, and we can help the team follow the appropriate ACLS algorithms. We can help the time, you know, how many minutes has it been since the last epi, and we're just not in the middle of that situation, and we're able to very objectively say, hey, it's time, you know, it's time for another epi, or it's time for a check. We're also able to step back and actually see, how are your compressions? Your compressions are at a good depth. Hey, your compressions are not at a good depth. It looks like you're getting fatigued. Why don't you let somebody else do compressions? And those are all things that we can do to help manage those patients while they're in the EICU, that has produced, that has helped us produce a lot of good quality outcomes. Here are some of the results that we that we have from our ICU. You can see that we're actually able to reduce our length of stay. We've improved some best practices. Our VTE prophylaxis, that's venous, that's the prophylaxis to prevent blood clots in the back of the leg in case we don't, in the calf of the leg. We were able to improve best practice with that. And we were able to improve making sure that the patients that are in the ICU are usually on a lot of medications that can cause GI upset or stomach ulcers, and so we make sure that they're on the right medications for that. Here are some of the impact statements from our EICU, and I'm not going to read through all of these, but I will hone in on the one case on this slide, and it is that our EICU nurse noted on video assessment rounds that a patient was receiving a paralytic and not receiving any sedation. So if I think back to, you know, the patient experience and keeping the patient in the center and making sure we're doing everything right for that patient in quality and reducing cost, this is one of those cases that truly stuck out to me. The right thing to do for the patient is to make sure they're sedated when they're on a paralytic. If I would, you know, and I think that whether we're nurses or not, that we can relate to that, and that in that it did reduce anxiety, and it was an error that could have reduced cost. And errors in the hospital, the most recent research is about each case, it costs us about $11,000. So every case that our EICU intervenes in or catches a med error or just catches a policy error that could relate to a poor patient outcome, it really is saving dollars, and it's increasing patient satisfaction and providing a better patient experience. So I want to talk a little bit about remote patient monitoring in a non-traditional setting. So we typically think about remote patient monitoring in a perspective of EICU or acute care. I challenge everyone to think innovatively in the acute setting where remote patient monitoring can be beneficial. And one of the programs that we have just designed and built is our Stork program. And this is proactive monitoring for labor and delivery patients. Many times in our situation, we'll get a call or we'll get a transfer from a baby, and our maternal fetal medicine specialist will say, oh, if I would have just got to them a little bit sooner. So we would have been able to do more. So this is that proactive monitoring, labor and delivery. We can pick up early signs of distress in the baby, early signs of distress in the mom. And then we can video in or call into the labor and delivery unit and say, hey, did you guys notice this was going on? And really provide that extra set of eyes and that proactive approach and sharing best practices with our community hospitals and labor and delivery units. One of the things that we want to do is we want to decrease those poor birth outcomes. And that's very important, and that's very important to us. This is a program that we just started, and so it's that it is a non-traditional way in remote patient monitoring in the inpatient setting, but it was an area that we found a need, and that is one thing that we do specifically in our program. So when you're thinking about building any program, I challenge you not to take a look at what the technology is out there, but talk to the physicians and talk to the clinicians and say, what's the problem and how are we going to solve the problem? And that's truly what we did with Stork. We said, you know, our docs came to us and said, we're getting all these patients that, you know, are transferring to us. And if they would have just done X, Y, or Z, or that would have been something that we could have picked up on a little bit earlier. So we really look to the problem, and we think about what that problem is, and we talk about best practices and what we need to do to make that problem better. And then we back our technology into it. So what we did with our Stork is it was a truly custom clinical solution. We actually used Epic Monitor, and anybody that knows anything about Epic Monitor, it's really built as a EICU or a Tele ICU program. In our EICU, we do use Philips. So we looked at, well, we knew that Epic had a module also. So we looked at it and said, okay, we really think that Epic Monitor can help us in our Stork solution. So we really truly built it out very specifically for the labor and delivery patients. We worked with our MFM specialists. We say, okay, this is what they like to see in the EICU, but your world is completely different. What do you want to see on this? So we leveraged our EMR, and we were able to embed video right into Epic and have a successful solution in our Stork program. So that really leads us, that really leads me to, when is that tipping point? When does your program become sophisticated enough where you say, okay, I want to stop using all the external support. I want to stop going through the outside vendors. And when do we really just build it ourselves, or take on that initiative to not use a lot of external support? And some of the key things that helped us be successful in this journey. And in our journey about 2 years ago, we decided to internalize everything, internalize our entire support for our telemed network, use our entire IS infrastructure to help support that. We build and design our own carts. We're completely vendor agnostic when it comes to what parts and pieces that we're using. And we really build from within. And as you're starting up, using external vendors is great. We used external vendors for several years, but I think that as you're growing your programs, most people will get to that point where it's like, okay, we have full executive support. It's in our strategy and in our growth plans that we want to grow our telemedicine programs, but sometimes we're held back by the speed of which the vendor develops and the speed of which you want to develop within your own organization. And that's really what happened to us. We wanted to be able to push out more custom programs and do more with our telemed platform than what our vendors could support. So we have a lot of executive support. We have support from the top down. Telemedicine is embedded in our strategy and growth plan. We have an IS infrastructure, and that's something not to underestimate, the level of IS infrastructure that you need. Many hospital systems, IS infrastructure, they're not used to thinking outside of the box, or they're not used to being innovative because they're bound by many HIPAA regulations and hospital security and compliance policies. Now you're telling the same group of people, okay, we're going to think innovatively and outside of the box. So we really do have to have a lot of support for that. And then also now they're not only supporting and being the service and help desk for within the organization, they now have to be customer and patient facing. And that's a new world for them. So it's an area definitely not to underestimate. The vendor relationships, you're still going to have to maintain relationships with vendors for carts and different types of devices. So you're always going to have some sort of relationship with them. Another key piece that makes us very successful in the ability to build and innovate is our dedicated telemedicine team. And I do have a slide that kind of shows the depth and breadth in that team, but we really do have that executive support. It's in our strategy, and it is supported to be able to have that dedicated team, that dedicated department. And so many times we get people that come to us and they say, how are you actually doing this? And it's like, well, we have a clinical performance team that helps us look at quality. We have a development team that helps us develop. We have a credentialing team that helps us with credentialing. And all of those pieces are truly needed to really support that infrastructure. And it really does come from our executive support, and telemedicine being a key piece of our strategy. And then you really need to stay connected with operations. We can have all the ideas in the world to develop and design new programs, but if we don't have doctors and the available physicians to provide the services, our growth stops right there. So those are some key features and key areas that you really want to think about as you're do I have sufficient support and knowledge in all of these areas to really internalize and build. So again, our team, we do stem to stern support, everything from workflow design, working through the billing aspects, legal and compliance. We do look at different technology solutions for our providers. Our team doesn't decide the technology. What we do is we talk with our clinicians, we talk with our clinical experts, and we say, tell me how you take care of a patient now. And what we're going to do is we're going to turn this into a virtual process, and it's going to be as good or better than an in-person visit. And so we don't even talk technology in the beginning. And for some physicians and some groups, they're like, well, I saw this technology and this is what I want to use, and we really do have to back them up. And it's like, let's keep the patient in the center. Tell me how you take care of your patients now, and we're going to get you to take care of those patients just as good in your virtual processes. We work with the vendors in the outside realm and say, okay, you want an ophthalmoscope? Let's look at 3 different ophthalmoscopes. We talk to our IS department. Will they integrate? And then we bring them in and let our physicians pick which one we're going to use. We also, we also do quality and clinical improvement and clinical performance programs. We have dashboards that meet with we have dashboards that show quality measures. We have a team that meets with our service lines on a monthly basis to review that. And we also do that same thing for our partner sites. We can be improving our quality here, but also a major role in our program is that we help develop the quality in the communities to really impact the population. This is a slide that just talks about what our program looks like and how many people that it actually takes. We have a dedicated team of 188 staff that's committed to providing care and supporting our telemedicine program. So when I say that we have executive support, we truly do have that executive support. Every year we ask for a little more money and a little more staff to be able to do the things that we do, but it is in the mission and vision of our executive team. So that is one thing that does help make us successful. And that is where I'm at the end. So Becky, I don't know if there's any questions out there.
Okay. Let's see. Andrew, do you have those questions?
Yes, there are a couple questions in the queue. We can start with the first one from Benjamin. He asks, for RPM, I saw that 30-day readmission and 30-day mortality were some of the metrics that were collected. What other clinical and operational metrics were being reviewed to measure the value of RPM?
So, we absolutely, we absolutely have more clinical metrics that we use. Each program is a little bit different. So, when we go to our clinical experts, so say we're going to do remote patient monitoring in the home for diabetes care, that program, our quality metrics for that program are going to be different than what it is for a different subspecialty. So, we really do look to the best practices of each specialty or each chronic disease that we're trying to manage, and we look at, okay, financially, where is the biggest bang for our buck, and what's the best clinical practice? So in diabetes, it might be readmissions with DKA, or following those best practices for diabetes care. Where in hypertension, it might be compliance with, it's compliance with blood pressure. And then we always look at the financial benefit and what's good about the financial benefit to the organization, and can we create provider efficiency? So what is the impact on preventing patients from having to come into the bricks and mortar, and can we save money there? We really look at how it affects, our medical director calls it the 4 Ps, patients, providers, payers, and people. So we really do look at that holistic approach and how we can affect all of those areas.
Perfect, thank you. We have 2 questions from Tom. He says, what operating efficiency have you experienced? And then he also asks, when is telehealth not appropriate?
So there are times when, so I'll do the second one first, because I think that's my favorite one. So there are times when telehealth is not appropriate, and what we will, many times people will say telehealth is there to fill a gap, and we do fill the gaps. I'll give an example of this. We just we want to do some telemedicine with our flight team, and telemedicine with our flight team is a great idea. But one of the things is that we're struggling with right now is our NICU pediatric transport, and our flight team really having a lot of expertise in that area. And yes, telemedicine can fill the gap and provide NICU support for the flight team, but it's not going to fill the gap in the lack of education. And that was one thing that our medical director that we're working with this program specifically stated, that we can put telemed in here, but we're not going to put telemed in here until we fix some of the people problem and some of the education and some of the knowledge-based problem. And without having that first, telemed can't fix all of that. So we really do, let's keep the patient in the center, and does it make sense? I'm a technology junkie. I'm the manager in development, and I'll say this to providers all the time. I can put a piece of technology just about anywhere, and I can give you a link to a patient just about anywhere, but does it make sense? And we do always look at, is this providing benefit to the patient, and is it safe? And then, is it cost effective, and is it going to give us any type of a return on investment? And so those are all things that we evaluate. So it's not wrong at all to say that telemedicine is not a good fit for a case. And what was the other question?
The other question was, what operating efficiency have you experienced?
So I think some of the biggest operating efficiencies that we've experienced was with patient scheduling. And this is across the board in telemedicine and with our remote patient monitoring, is that with allowing them you know, with some remote patient monitoring, we're not getting as many clinic visits. We can actually prevent some of the clinic visits. It's able to open up their schedule for higher acuity cases to come into the clinic, which on the flip side of that then does create that challenge where they go, you know, our physician providers then sometimes say, but sometimes I really liked that lower acuity patient. It gave me a break in my day. So there is a little bit of a balance there, but we are seeing that, you know, some of those lower acute clinic visits we can avoid. In our telehealth programs in general in the clinic, what we've been able to do is create operational efficiencies in the sense of, if I have a physician that's stationed in New Orleans, I can see patients in New Orleans at 9, I can see patients in Baton Rouge via video at 10, and I can see patients in Covington at 11. So we're really able to decrease, you know, there is no more travel time or windshield time, which has really created operational efficiencies for us also.
Thank you. So we do have a few more questions in the queue still. The next one. Do you do anything with asthma management and PFM integration with EHR?
We currently do not do asthma management yet. It doesn't mean to say that we're not going to do it, but we're not currently doing that. And the second half of that was what with EMR?
She said PFM integration with EHR. I wonder if she meant RPM integration with your EHR.
Okay, so our remote patient monitoring, we do integrate that with our EHR. We do our Epic team, and that is a very important piece. We were just talking with one technology vendor that has a home model that we were looking at, and I asked the question, I said, does this integrate with it? We use Epic, it doesn't matter what you use, you know, and my question was, how does this integrate with Epic? Because if I have to double document, or if I can't create efficiencies and leverage my EHR to work for me, then purchasing another piece of technology sometimes isn't the best way. And a lot of times that's when we decide to try to build within ourselves.
All right, and Brenda did mean a PFM as peak flow meter, but I assume you're probably not using anything like that if you're not doing
if we don't have asthma programs, no. Many times a lot of the technology vendors will tell you, yes, we integrate, but then the flip side to that is, in my experience, has been it's usually on the organization side to pay for the interface.
And now we have, I think this is probably a pretty popular question. Can you address how, if you're being reimbursed by insurance carriers for any of your RPM?
So, so there is reimbursement for remote patient monitoring. It is reimbursed at $46 a day. That is new. But right now, a lot of our remote patient monitoring is truly being done with our bundled payments. And we're using it to create efficiencies and prevent readmissions, and really starting with our bundled payment population.
And the $46 you mentioned, is that, which payer is that for? Can you say?
That's actually being reimbursed by Medicare.
Oh, okay.
Mm-hmm.
Now, our last question, everyone feel free to, we still have another 15 minutes or so feel free to ask more questions. The next one, have you had any HTA to telemedicine application or devices? And if so, what has been your approach?
HTA.
I'm not sure if I know what that means either. So maybe if you can define what HTA is for us. In the meantime, what is the biggest challenge you've had to establishing RPM?
So probably one of the biggest challenges we face is being good stewards and finding what the right where the right places to start are. There's so many things out there that we can do in remote patient monitoring. There's a technology out there for just about anything. I talked about the idea that just came to us from therapy services, but it really is working within your organization, where your strategic plan falls, where your organization needs the help and needs the work, and doing that analysis and saying, this is where our pitfall is, and this is where we should start. In my mind, in telemedicine, I think we should do it all. I've obviously drank the Kool-Aid, but it really is finding the right population to start with and proving the value. And that's on the flip side of that. Your organization and your executives are always going to be asking you, well, what's the value? What am I saving? And sometimes cost avoidance is difficult to prove in those situations, and difficult to get the financial experts and executives to really grasp.
Very good. So HTA was health technology assessment. So have you done a health technology assessment for your telemedicine applications?
You know, we don't have anything formal that we use. Usually when we're assessing technology, we're working with our clinical provider. We do try to use Epic as much as we can. We know that there are limitations to that. So an example of that is when we developed our Stork program, we did build Epic for the remote monitoring piece of the mom, but we knew that that's where Epic fell short, is remote monitoring of the fetal strips. So we then, in conjunction, it was a new transition to a different program that we're now using for our L&D strips. So a lot of times what we do is we really just look at the specialty and look at what their need is.
Okay, so we do have a few more questions that have come in. The next one, have you had to deal with any lawsuits related to the fact that care was provided via telehealth?
Luckily, we have not. That is one thing that we have, that we've not done, or not come into that. We have talked to some other organizations and been in conversation, and I think it was a few months ago, I was at the CTEL conference, and there was a conversation and a great talk on whether or not there's litigations for places not having access to telemedicine experts. And that it actually kind of made me excited that that's the level of adoption that we have, and the level of evidence that we have that telemedicine is supported.
Very good. And yeah, the CTEL, Center for Telehealth and eHealth Law, is a great resource. And as I understand it, there haven't been any lawsuits settled in court around telemedicine. And there is, everyone always brings up that lawsuit that a hospital didn't have telemedicine, which I think was settled out of court. But yeah, very exciting. Going back to billing for Medicare, can you say what billing code are you using to get the $46 a day reimbursement?
You know what? I don't have that off the top of my head. We just had this conversation. Is there a way that I can get that to you and you can get it out to the group?
This is Becky with TexLa. We have developed a billing guide with regard to remote patient monitoring, and you can contact us, and we'd be glad to get that information to you.
Great. Yeah, I just don't have it in front of me.
Perfect. And Becky, maybe that's something we can email all of the attendees after the webinar?
Yes.
Perfect. For the next question, does Medicaid in Louisiana cover telehealth?
We have not received anything from Medicaid. Louisiana, we're really not receiving anything from Medicaid.
And I can say that in Texas, currently 2 diagnoses are covered for remote patient monitoring, diabetes and hypertension. In Medicaid here is working to add more.
Yeah, we're our medical director and VP sit tight with the legislation and do a lot of lobbying, but Medicaid in Louisiana just isn't there yet.
Mm-hmm. And as many of the attendees may know, the Medicaid policies really vary quite drastically around the country. I'm in the Northeast with the Northeast Telehealth Resource Center, and Maine just recently adopted a new rule for telemonitoring, but for the most part, other Medicaid programs are not.
Yeah, I am. I did not realize that until I'm originally from Pennsylvania. And so when I moved to Louisiana, I had a whole new set of rules to learn.
Mm-hmm. It can get complicated. The next question, have you considered in-home patient monitoring post-discharge?
Yes, yes, we have. That is actually what we're doing in our congestive heart failure patients. There are patients that are identified in the hospital that are sent home with their scales and their digital tablets. If they meet certain criteria, then they fall into the congestive heart failure program at home.
Very good. The next question, we're looking at potential public health integrations, maybe chronic disease self-management classes, local resource location, etc. Are you utilizing public health at all, or can you suggest where you might see the benefit of RPM programs in public health?
We are not, and so that's I really can't speak to that, but we're not using resources in our public health programs currently.
And that seems to be a conversation we're seeing start to develop more and more. We do hear from some public health departments in the Northeast who are exploring how they might use telehealth in a variety of ways. Our colleagues at the Center for Connected Health Policy just a few months ago released a white paper on TB and directly observed therapy using mHealth and telehealth. And we're also, Jennifer, we're presenting a learning institute at the American Public Health Association in October. So please feel free to reach out if you'd like to learn more about that.
Yeah, that would be great. So when we do hire on our team, we are expanding, and I actually just hired someone, and their master's is in public health, and she worked with some public health agencies and AIDS clinics, and we're hoping that she brings that level of expertise to our team. So that is one thing when we hire in, we really do look at the dynamics and the background of each person and try to fill the gap in those areas of telehealth that we need.
Very cool.
Yeah.
So then the last question we have in the queue right now, what's the scale of the service? How many beds, patients covered? How much more is this than you could have served using traditional methods?
So for acute care, we're currently monitoring 160 beds in our EICU, and our EICU is now a conjunction of Philips and Epic Monitor. We use Philips for most of our remote patient monitoring, but some of our lower acuity or critical access hospitals that are on our Epic, this is a service that we're now able to offer to them, where an example is we have a small hospital that has a 2-bed ICU. They're on our they're one of our hospitals. They're on our instance of Epic. They would never be able to really afford or justify the cost of some of the other softwares out there for EICU. So we built them into our Epic Monitor program and can really offer that to them at a low cost. So that's another one of those cases of, what's the problem, and let's solve the problem and then back the technology into it.
Okay. I would just say, like we showed you the map in the very beginning of the telehealth resource centers that cover the nation. All those policies are with regard to reimbursement are very different. So contact your telehealth resource center in your region, and they'll be able to give you better information. So Jennifer, we really thank you for the presentation. There was a lot of good information. Once again, this presentation has been part of the National Telehealth Resource Center's webinar series. And it usually happens monthly. The next webinar is scheduled for Thursday, October 20th, and will be presented by the Southeast Telehealth Resource Center. We will send out announcements about that. And we do really value your opinion and ask that you take a few minutes to fill out the online survey. You see the link with the SurveyMonkey. Thank you.